Hello there, my dear listeners, and welcome back to your channel of choice. My name is Dr. Nath Arwa. I am a clinical pharmacist by profession. I am the founder of Progressive Pharmacotherapy Consultants, a premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management, and optimal treatment and clinical outcomes are very crucial and non-negotiable to us. Here, we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services, so I urge you to sit back and spare me part of your precious time to share some tips with you. So welcome to part 26 of our pharmacotherapy MCQ series. So first question reads, J or J, a 66-year-old African male patient, presents to the cardiac clinic at your hospital. He has a past medical history of hypertension, coronary artery disease, and he experienced an MI 1 year ago. He is currently taking 12.5 milligrams of hydrochlorothiazide in the morning after breakfast, 10 milligrams of lisinopril once daily, and an echo is performed which shows a left ventricular ejection fraction of 51%. He's not doing badly. He has a BP of 135 systolic and 96 diastolic, and he has a heart rate of 81. His pertinent labs are sodium of 131, potassium of 4.4, serum creatinine of 1.2. So my question to you is, which of the steps listed below would be your next best step or course of action? Would you increase the hydrochlorothiazide dose by doubling it and adding the fixed dose combination of valsartan sacubitril, or would you continue the hydrochlorothiazide at the same dose and add metoprolol succinate to it? Or would you discontinue the hydrochlorothiazide and initiate carvedilol twice daily? Or would you continue the regimen and add spironolactone to it? I'll give you 10 seconds to choose the correct answer. So in my opinion, C is the correct answer. I would discontinue hydrochlorothiazide and start carvedilol. Now J or J is experiencing hyponatremia with the use of hydrochlorothiazide, and it needs to be discontinued. He has a history of MI, and this is a compelling indication to have a beta blocker as part of his antihypertensive regimen. Carvedilol is a non-selective beta blocker which will help to lower his blood pressure. Now, all regimens that don't include a beta blocker are inferior because of this gentleman's past history of an MI. Africans like him historically respond well to hydrochlorothiazide, but due to the hyponatremia, continuation of hydrochlorothiazide would be inappropriate at this stage. Now, valsartan sacubitril shouldn't be used, and I repeat, shouldn't be used in combination with an ACE inhibitor such as lisinopril that our dear friend is on, and is only indicated for chronic half-ref, not in this particular case. Remember, he has a preserved ejection fraction of around 51. Spironolactone may worsen his hyponatremia, so I wouldn't opt for it either. Let's move to the next question, which reads, AWT is a 65-year-old Kenyan man who reports to the clinic for continued evaluation of dyspnea on exertion. A 2D echo shows a left ventricular ejection fraction of 55%, non-dilated left ventricle, and concentric left ventricular hypertrophy. Now, assuming you do not know or do not have his past medical history or the current medications he's taking, what, in your opinion, would be the cause of AWT's 2D echogram results that have been listed above? Is it aortic aggregation? Is it alcoholic cardiomyopathy? Is it hypertension, or is it mitral regurgitation? I'll give you 10 seconds to choose the correct answer. So hypertension it is. Hypertension is the most common cause of HFpEF in the setting of non-dilated left ventricle and concentric left ventricular hypertrophy. In the other three options listed above, you would expect to see a dilated left ventricle and eccentric left ventricular hypertrophy. That's why I am strongly in favor of hypertension. Let's move to the next question. EAA is a 57-year-old female who presents to the clinic with the following lab results. Total cholesterol is 218, TG is 153, HDL is 51, LDL is 139, and he has an A1C of 5.9. She currently takes no prescription medications. She follows a healthy diet and doesn't use tobacco, neither does she drink any alcohol. She has an atherosclerotic vascular disease risk score of 2.3, pretty low, and her lab results indicate both her liver and her kidneys are within normal limits. They are functioning pretty well. So my question to you is, which of the recommendations below would you make with regard to her management? Would you start high-intensity atorvastatin at a dose of 40 milligrams at night? Or would you start fish oil? Or would you opt for rosuvastatin at a dose of 5 milligrams at night? Or would you initiate lifestyle changes to reduce her risk factors? I'll give you 10 seconds to choose the correct answer. I would initiate lifestyle changes to reduce her risk factors. Now, this lady has a very low 10-year atherosclerotic cardiovascular disease risk of below 5. It's 2.5 if I remember well. At this point, it is important to emphasize lifestyle changes to help reduce her risk factors. A diet rich in vegetables, for example, legumes, nuts, whole grains, and fish is recommended to minimize those risks. Now, she should also minimize the intake of refined carbohydrates and sweetened beverages, the sodas. And she should actually, in my opinion, engage in at least 150 minutes of moderate intensity or 75 minutes of vigorous intensity aerobic exercise every week, every single week. And she doesn't have elevated TG, it's not above 500 to warrant fish oil therapy. Atorvastatin 40 milligrams at night is high intensity statin therapy, and she has a low risk. The score was pretty low, so she doesn't need atorvastatin at this moment. A high intensity statin therapy such as that would be appropriate if her risk was 20 or above. So she doesn't qualify for that intervention. Then rosuvastatin at 5 milligrams is described as moderate intensity statin therapy, and it can be considered, but when the risk lies between 5 and 20, so our patient does not qualify. Then for patients aged between 45 and 75 and with an LDL of 79 to 189 without diabetes mellitus, with a 10-year risk score, a 10-year risk score needs to be determined before you decide on the course of therapy. Now, if the risk is equal to or above 5, with the risk enhancers, such as the ones we've mentioned above, discussions regarding moderate intensity statin may be appropriate. Now, if the risk score is 20 or above, then it's time to initiate high-intensity statin therapy to reduce the LDL by 50 or more percent. Now, the examples of the SCVD risk enhancers include a family history of premature SCSVD, elevated LDL, which is 160 or above, chronic kidney disease, metabolic syndrome, preeclampsia in the pregnant ones, premature menopause, inflammatory diseases such as rheumatoid arthritis and psoriasis, or even HIV, AIDS. It can have inflammatory states accompanying it. And then the South Asian ethnicity is also an issue here. So those were just by the way. Let's move to the next question. Which of the loading doses for antiplatelets listed below confers the greatest degree of antiplatelet activity, which is a de facto inhibition of platelet aggregation? Is it Ticagrelor, a single dose of 90 milligrams orally? Is it Clopidogrel at a dose of 600 milligrams stat? Or is it Prasugrel at a dose of 60 milligrams stat? Or is it Clopidogrel at a lower dose of 300 milligrams stat? I'll give you 10 seconds to choose the correct answer. My opinion, Prasugrel it is. Now, in a three-way crossover study comparing Prasugrel, 60 milligrams loading dose and 10 milligrams daily maintenance dose to Clopidogrel 600 loading with 75 maintenance and Clopidogrel 300 with 75 maintenance in 41 healthy aspirin-free subjects, the Prasugrel 60 mg loading dose achieved greater inhibition of platelet aggregation by 1 hour. It was 82% to be specific, and by 2 hours it was 91%. And that was greater than the 6-hour peak in the case of the 300 milligram Clopidogrel loading dose, which reached 51%, and the 600 milligram loading dose, which reached 69%, with a p-value of less than 0.01. So that was a comparison of 5169 compared to the values of Prasugrel that were in the 90s, quite a substantial difference. So that gives it superiority over Clopidogrel at higher doses or Ticagrelor. So in my opinion, Prasugrel is the best option in this particular case. Let's move to the next question. Amiodarone and Sotalol are accidentally administered to 2 different hypokalemic patients admitted to your ICU. Now, my question to you is, if this happened, which ECG abnormalities would you expect to observe in both of these 2 cases? Would you expect Q arrest narrowing? Would you expect QT prolongation? Would you expect PR interval shortening? Or would you expect T-wave inversion? I'll give you 10 seconds to choose the correct answer. QT prolongation it is. Now, both of these drugs are class 3 antiarrhythmic drugs, which are most commonly associated with prolonged or prolongation of the QT interval due to their inhibition or delay in ventricular repolarization, which occurs during phase 3 of the action potential of the cardiac myocytes. QT interval prolongation with the use of these 2 drugs is worsened by the presence of hypokalemia, hypomagnesemia, or hypocalcemia, just for your information. Let's move to the next question, which reads, a 63-year-old Hispanic male presents to the cardiac clinic for evaluation and management of hypertension. He has no complaints and states that he is feeling good. He claims his type 2 diabetes mellitus is well controlled and confirms his compliance with his regimen. Now, his past medical history includes coronary artery disease. He's had cabbage 5 years ago. His diabetes was diagnosed 15 years ago. The hypertension was diagnosed 10 years ago. And he takes 81 milligrams of aspirin once daily prophylactically. He takes 10 milligrams of amlodipine. He administers 15 units of insulin aspart before each meal and administered the basal insulin glargine at bedtime at a dose of 40 units subcutaneously. Apart from that, he takes 40 milligrams of lisinopril once daily, and he takes a gram of metformin twice daily, after breakfast and after dinner. His BP is 140 systolic, 89 diastolic. You take a while, let him relax and repeat the measurements. And this time they are 145 systolic and 91 diastolic. They've risen slightly. And he has a heart rate of 86. He weighs 110 kilos. All his labs are within normal limits, but the A1C is off the mark a bit. It's reached 7.1. Now my question to you is, which of the antihypertensives listed below would be the most appropriate option to improve his blood pressure control? Would you opt to add hydrochlorothiazide 25 milligrams once daily after breakfast to his regimen? Or would you add 25 milligrams of metoprolol succinate twice daily after food? Or would you increase his amlodipine dose by doubling it? Or would you discontinue lisinopril and replace it with losartan at a low dose of 25 milligrams once daily? So I'll give you 10 seconds to choose the correct answer. Settle for adding metoprolol succinate 25 milligrams twice daily to his regimen. Now his ideal blood pressure goal should be less than 130/80. He would benefit from additional blood control because his pressure is a bit on the higher side. Now adding metoprolol and hydrochlorothiazide would be reasonable options to consider, since amlodipine and lisinopril are already at their therapeutic maximum doses, and increasing them would add no value, both monetary and therapeutic. Given the compelling indication of coronary artery disease, the addition of a beta blocker, which is metoprolol in this case, would be the more appropriate option. Now, discontinuation of lisinopril, an ACE inhibitor, and replacing it with losartan and ARB does not make therapeutic sense to me at all. And if I look at it, the losartan dose is on the lower end of the dosing range. 25 is a bit too low. This change would be essentially decreasing his renin, angiotensin, aldosterone system control, which would have a negative impact on his state. Let's move to the next question. Which statement or statements is or are accurate regarding diltiazem use in adult patients? Is it true that it can improve symptoms of GERD? Is it true that it can prevent cardiac remodeling? Or is it true that it can decrease inotropy? Or is it true that it inhibits CYP3A4 and P-glycoprotein transport system? Or is it true that it can cause constipation? I'll give you 10 seconds to choose the correct answer. Opinion C, D, and E are all correct. Diltiazem is a non-dihydropyridine calcium channel blocker, which is classified as a class 4 antiarrhythmic agent due to its effect on the atrioventricular nodal conduction, which reduces the pulse of the patient or the user. It also causes negative inotropic and chronotropic effects on the heart. It lacks the ability to inhibit cardiac remodeling and to protect sudden cardiac death, like the beta blockers, which is why it should be avoided in heart failure unless no other options exist. Now, it's useful for patients with AFib plus RVR without any underlying WPW. Now, side effects of diltiazem include constipation because of the way it relaxes the smooth muscles. It can worsen GERD due to the fact that it relaxes the lower esophageal sphincter muscles. And it can also cause bilateral lower extremity edema with the chronic use. Now, its drug-drug interactions are attributed to its inhibition of the CYP3A4 and the P-glycoprotein. So that explains why the last three answers are correct. Let's move to the next question, which reads, which statement below is true regarding the use of warfarin in the prevention of cardiovascular stroke in patients with AFib? Is it warfarin therapy is recommended for 14 days after cardioversion to normal sinus rhythm? Or is it true that warfarin therapy is recommended for 21 days prior to cardioversion to normal sinus rhythm? Or is it true that the risk of intracranial hemorrhage with warfarin increases with the warfarin increase once the INR exceeds 2? Or is it true that warfarin inhibition prior to cardioversion is necessary once the patient has been in AFib for 24 hours? I think that should be warfarin initiation. So I'll give you 10 seconds to choose the correct answer. The correct answer is B. Now, warfarin therapy is recommended with a therapeutic INR for 3 weeks prior to cardioversion. And therapeutic INR is considered to be between 2 and 3. And the risk of intracranial hemorrhage increases once the INR exceeds 3, not 2. And then warfarin initiation is indicated prior to cardioversion after the patient has been in AFib for greater than 48 hours, not 24 hours. So that makes alternative B our best choice. Let's move to the next question, which reads, ASM suffers from pulmonary hypertension and is on furosemide, warfarin, and he has been initiated on macitentan. Now, my question to you is, which of the following actions would be necessary or rational following the initiation of macitentan for the pulmonary hypertension in ASM? Would it be to decrease the warfarin dose, increase the warfarin dose, increase the furosemide dose, or decrease the furosemide dose? I'll give you 10 seconds to choose the correct answer. So I would opt to increase the furosemide dose, and this is the reason why. Initiation of macitentan is associated with an increase or increased incidence of peripheral edema following its initiation. Now, increasing furosemide would be appropriate to manage this edema by getting rid of the excess fluid. Unlike bosentan, which is a CYP3A4 and a CYP2C9 inducer, macitentan doesn't have any drug-drug interactions with warfarin. So I would not tamper with the warfarin doses. Now, just for your information, ambrisentan, bosentan, and macitentan are all endothelial receptor antagonists, which may cause peripheral edema when they are used to treat pulmonary hypertension, and when they are used, it would be necessary to adjust the loop diuretic dose quite often to control the adverse events. Now, warfarin is indicated for patients with pulmonary hypertension with a target INR of 1.5 to 2.5, just for your information. So you have to watch the INR carefully as you treat these patients with both warfarin, furosemide, as you administer macitentan as the main drug. Let's move to the next question, which reads, which of the drugs listed below can be administered during Cangrelor infusion? Is it Ticagrelor, Abtuximab, Prasugrel, or Clopidogrel? I'll give you 10 seconds to choose the correct answer. So, Ticagrelor it is. Now, Cangrelor is a P2Y12 platelet inhibitor indicated as an adjunct to PCI for reduction of the risks of periprocedural MI or repeat coronary vascularization and stent thrombosis in patients who have not been treated with a P2Y12 platelet inhibitor and been given a glycoprotein 2B3A inhibitor. Now, patients receiving glycoprotein 2B3A inhibitors or for whom these inhibitors are planned were not eligible for the Cangrelor trials. Now, Abtuximab is another GPI that is used as an adjunct to PCI for the prevention of cardiac ischemic complications in the case of the procedure. Clopidogrel, Prasugrel, and Ticagrelor are all oral P2Y12 platelet inhibitors, just for your information. And the expected antiplatelet effect of 600 milligrams of Clopidogrel as a loading dose, or 60 milligrams loading dose of Prasugrel, were blocked when they were administered during Cangrelor infusion, according to those studies, while the effect of 180 milligrams of Ticagrelor loading dose weren't altered significantly during the Cangrelor infusion. And that makes me opt for answer A as my correct answer. Let's move to the next question, which reads, AGT is a 59-year-old male patient who presents to the clinic 14 days following a recent diagnosis of hypertension. He has a past medical history of type 2 diabetes mellitus with albuminuria, and he is depressed. He is currently taking 5 milligrams of lisinopril once daily, 12.5 milligrams of hydrochlorothiazide after breakfast, and his pressure at the clinic is 133 systolic, 80 diastolic with a heart rate of 65. His sodium levels are 139, potassium 4.4, and his albumin to creatinine ratio, what we abbreviate as UCAR, is 250 milligrams per gram. He has a serum creatinine of 1.6, and his baseline 14 days ago was 1.3. So my question to you is, which of the approaches listed below would be the best for managing AGT's hypertension? Would you continue lisinopril and recheck the labs in 2 weeks? Would you discontinue lisinopril and start amlodipine 5 milligrams once daily? Would you discontinue lisinopril and start losartan 100 milligrams daily? Or would you increase lisinopril to a dose of 40 milligrams once a day? I'll give you 10 seconds to choose the correct answer. So in my opinion, I would continue lisinopril and recheck the labs in 14 days. Now, ACE inhibitors such as lisinopril often cause an acute increase in serum creatinine upon initiation. Their discontinuation is only needed if the serum creatinine increases by over 30% within the first 2 months of starting therapy, despite a dose reduction. Now, our patient AGT serum creatinine increased by around 23%, and it would be appropriate to continue the medication and recheck his labs in 1 to 2 weeks. He has a compelling indication for ACE inhibitors with his history of type 2 diabetes mellitus with albuminuria, and the discontinuation of lisinopril at this stage is unwarranted because of the lab works as they stand. Now, increasing lisinopril and hydrochlorothiazide doses may worsen his renal function. It's therefore important to start both at low doses and titrate them upwards slowly to avoid acute kidney injury. Now, both S inhibitors and ARBs can cause transient increases in serum creatinine, and discontinuation is only necessary, as I said, if the increase is over 30% in the first 60 days starting the drug despite dose reduction. Hence, switching to losartan would also be unwarranted at this stage. Now, additionally, starting losartan dose is usually 25, which is titrated stepwise to higher doses. We would not go straight to the 100 milligram dose. That would be inappropriate. It would also be appropriate to discontinue S inhibitors or ARBs if the serum creatinine increased by over 1 milligram per deciliter. Now, S inhibitors and ARBs are recommended for hypertensive patients with UCAR of between 30 and 299 milligrams per gram. And the main reason is to prevent worsening of albuminuria. So I strongly feel our patient urgently needs to be on the S inhibitor. I would be reluctant to discontinue it at this stage. Let's move to the next question, which reads, you initiated a thiazide diuretic treatment of hypertension in a male patient at your cardiac clinic. Which hemodynamic parameters would you expect to be affected, which would also continue or contribute, to the reduction or in his blood pressure? Is it a reduction in heart rate, a reduction in plasma volume, an increase in afterload, or an increase in inotropy? I'll give you 10 seconds to choose the correct answer. In my opinion, it's a reduction in plasma volume. Thiazide diuretics such as hydrochlorothiazide, indapamide, and chlorthalidone, and even metolazone primarily reduce plasma volume due to their ability to reduce the absorption of both sodium and water in the distal convoluted tubule of the nephron. They do not commonly affect inotropy or pulse. Now, in the reduction of plasma volume, there is an eventual stabilization of cardiac output and reduction of peripheral vascular resistance of the cardiac vascular resistance, thereby reducing both systolic and diastolic blood pressures. That explains why B is the correct answer. The next question reads, which of the statements below is accurate about the administration of epinephrine? Is it true that it can't be administered down the endotracheal tube? Is it true that concentrations of 1 to 1000 or a milligram per ml can be administered IV or intraosseous? Or is it true that concentrations of 1 to 10,000 or 0.1 milligrams per ml can be administered IV or intraosseous? Or is it true that continuous drips can be administered via IV without a pump? I'll give you 10 seconds to choose the correct answer. So C is the correct answer in my opinion. Now, due to confusions, epinephrine is no longer expressed in ratios, but rather in concentrations. For example, the 1 to 1000 is expressed as 1 milligram per ml, and the 1 to 10,000 is expressed as 0.1 milligram per ml. Now, epinephrine at 1 milligram per ml should only be used IM or sub-Q, and concentrations of 0.1 milligram per ml can be administered via IV or intraosseous due to the potential for proarrhythmic effects of epinephrine and the risks of unexpected or exaggerated changes in cardiovascular hemodynamics, which could occur with the 1 milligram per ml concentration. Now, epinephrine that is used as a drip or via infusion should always be administered via a pump to avoid overdosing accidentally. Epinephrine can be administered down the endotracheal tube, but it's not a reliable or a recommended method, but it's a possibility when we are out of options. So because of all those many words, option C is the correct one. Let's move to the next question, which reads, WJK is a 71-year-old male weighing 95 kilos and is rushed to your A&D with a chief complaint of chest pain and dyspnea. He was seen at the same A&D 2 days ago for an arm fracture where the intervention was surgical reduction and splinting, and he was discharged home the following day. You do a CT which is suggestive of a pulmonary emboli, and the bedside point of care doesn't suggest right ventricular dilation. Now, the clinical team would like to administer alteplase. So my question to you would be, which of the actions listed below would be the most appropriate for Mr. WJK at this moment? Would it be the administration of tenecteplase at a dose of 50 milligrams via IV bolus instead? Or is it true that alteplase is contraindicated in this case? Or would you administer 100 milligrams of alteplase with 10% of it as bolus and the remainder as infusion of 120 minutes? Or would you administer 0.9 milligrams per kilo IV with 10% as bolus and the remainder as infusion over 60 minutes? I'll give you 10 seconds to choose the correct answer. So according to me, it is contraindicated. Now, WJK has had a recent surgery, which is a contraindication for any form of fibrinolysis. However, he may receive anticoagulation. If he was eligible for fibrinolysis, 100 milligrams IV, administered as 10% of it being bolus and the remainder over 120 minutes would have been the appropriate dose. Now, the other dose, 0.9 milligrams per kilo, is a regimen for stroke patients, not for PE. Then tenecteplase is primarily used in STEMI patients. Now, the contraindication to alteplase for the treatment of STEMI and PE are active internal bleeding, history of recent stroke, recent, that is within 3 months, intracranial hemorrhage or interspinal surgery or serious head trauma, or the presence of intracranial conditions that may increase the risk of bleeding, such as an intracranial neoplasm, arteriovenous malformation, or an aneurysm. Or if there was non-bleeding diathesis or severe uncontrolled hypertension, I would also be reluctant to administer this drug. Now, patients taking antiplatelet drugs such as Clopidogrel, Ticagrelor, and Prasugrel, and even aspirin, aren't considered to have a contraindication based on these drugs alone. However, they are at a higher risk of hemorrhage complications. So, if we opt to use alteplase, it must be used with caution. Now, patients with severe uncontrolled hypertension may receive pharmacologic interventions to lower the blood pressure to less than 185 systolic, 110 diastolic, if they are to receive it. And if they require sodium nitroprusside to control their pressure, then that would be a no-no. I would not give them fibrinolysis. That's just a by the way to clarify why B is the correct answer. Let's move to the next question. AFD is a 45-year-old white female who presents to your hospital for evaluation for the management of her dyslipidemia. She has a past medical history of type 2 diabetes mellitus and she is hypertensive. Her dad had an MI at the age of 62 and suffers from type 2 diabetes mellitus, hypertension, and dyslipidemia. The mother suffers from type 2 diabetes mellitus. She's hypertensive and has dyslipidemia. And she tells you she doesn't smoke tobacco, she doesn't drink alcohol, neither does she use any illicit drugs. She's currently taking a gram of metformin after breakfast and after dinner, and she administers 40 units of insulin glargine at bedtime as her basal insulin and 12 units of insulin lispro before each meal as her bolus insulin. Apart from that, she takes 40 milligrams of lisinopril orally once a day and 25 milligrams of hydrochlorothiazide after breakfast. She has a blood pressure of 125 systolic, 77 diastolic, and a heart rate of 68, and she weighs 135 pounds. Labs include a total cholesterol of 264, HDL of 52, LDL of 155, a total TG of 284, and an A1C of 7.5%. So my question to you is, which of the following interventions would be the best or the most appropriate for Lady AFD? Would you target an LDL goal of below 130 and add cholestyramine to her regimen? Or would you target a goal of below 100 and add gemfibrozil? Or would you target a goal of below 100 and add rosuvastatin? Or D, would you target a goal of below 130 and add ezetimibe? I'll give you 10 seconds to choose the correct answer. So C it is. I would target a goal of below 100 and add rosuvastatin. Now remember, AFD has an LDL goal of below 100, or would likely benefit from moderate intensive statin therapy that would provide at least a 30 to 50% reduction in LDL cholesterol because of the readings above. Now, rosuvastatin would be the most appropriate option to target LDL lowering in AFD's case and would easily achieve the recommended reductions that we desire compared to the others. Ezetimibe would be added on to a statin if statin therapy alone is not sufficient. Now the others would be inappropriate for her case at the moment. Let's move to the next question. Z.B.N. is a 40-year-old male patient who was evaluated at your hospital for chest pain. He was found to be a low risk after the cardiac stress test. Now, for how long would you recommend Z.B.N. takes dual antiplatelet therapy with aspirin and Clopidogrel or Ticagrelor as an outpatient? Would you do it for up to half a year, 1 year, 3 months, or 30 days? I'll give you 10 seconds to choose the correct answer. Do it for 1 year. Now, dual antiplatelet therapy is recommended for at least 12 months, and this is a class 1 recommendation in the Unstable Angina Stroke NSTEMI Forecast Update, which was published. Now, the authors suggest weighing the benefits of dual antiplatelet therapy against the risks of bleeding. So you can do it for a year, but watch carefully. Let's move to the next question. EKP is a 67-year-old white male patient who presents to the heart failure clinic. He has a past medical history of hypertension, type 2 diabetes mellitus, congestive heart failure, and is classified NYHA class 2 with heart failure with reduced ejection fraction, HFrEF. He is currently taking 160 milligrams of valsartan once daily, 200 milligrams of the sustained release or extended release metoprolol once daily orally, and 25 milligrams of spironolactone once a day at breakfast. His vitals include a blood pressure of 133 systolic, 80 diastolic, with a heart rate of 60. He reports occasional shortness of breath on exertion, and his labs are within normal limits. So my question to you is, which of the therapeutic plans listed below would suit EKP the most? Would it be to discontinue valsartan and substitute it with the fixed dose combination of valsartan sacubitril? Or would you increase the valsartan dose by doubling it to 320 milligrams once daily? Or would you increase the metoprolol succinate dose to 200 milligrams orally twice daily? Or would you leave everything as is at the moment? I'll give you 10 seconds to choose the correct answer. So I would opt to discontinue valsartan and substitute it with valsartan sacubitril as a fixed dose combination. Now, according to the AHA and ACC and the Heart Failure Society of America heart failure guidelines, they recommend replacing ACE inhibitors or ARBs with valsartan co-formulated with sacubitril in chronic symptomatic heart failure patients to further reduce morbidity and mortality. Now, our friend EKP is already at targeted doses of ARB, valsartan, and no further dose increase is warranted. I wouldn't go beyond that level. Now, increasing the metoprolol succinate dose to 200 BD is not necessary, and it isn't an approved dose for the treatment of heart failure. And we know from the statement above that EKP is experiencing symptoms of heart failure, and it would be appropriate to make changes now to further improve his quality of life. So that disqualifies B, C, and D. Now, the Paradigm HF trial showed that valsartan sacubitril reduced morbidity and mortality in heart failure patients. And just for your information, if switching from ACE inhibitors or ARBs, ACE inhibitors to be specific, and replacing with valsartan sacubitril, it is recommended that you allow 36 hours of washout before initiating the fixed dose combination. A washout period isn't required if you are switching from an ARB to valsartan sacubitril, just for your information. And then I would like to emphasize that valsartan sacubitril is contraindicated in patients with a history of angioedema related to previous use of ACE inhibitors or ARB therapy. That's the only condition where I would be reluctant to substitute the ACE inhibitor with valsartan sacubitril. Let's move to the next question, which reads, which of the inotropic medications listed below inhibits the activity of phosphodiesterase 3 and is sometimes used for the treatment of heart failure with low cardiac output? Is it theophylline, milrinone, dobutamine, or dopamine? I'll give you 10 seconds to choose the correct answer. So milrinone it is. Milrinone is a selective phosphodiesterase 3 inhibitor that has a positive inotropic effect. That is, it increases cardiac output from the heart point of view. Now, dobutamine is an inotropic agent that preferably stimulates beta-1 receptors on the heart with some stimulatory activity to the beta-2. Now, dopamine, on the other hand, exhibits dose-dependent effects on a number of receptors. At a lower dose, it stimulates the dopamine receptors. At a medium dose, it starts to stimulate the beta-1 receptors. And at a higher dose, it does stimulate alpha-1 receptors. Now, theophylline, on the other hand, is a non-selective inhibitor of the phosphodiesterases. It inhibits more than one phosphodiesterase, and it can increase the contraction of some muscles, such as the diaphragm, and it isn't used for low cardiac output states, such as those seen in heart failure. Just by the way. Let's move to the next question. JOK, a 55-year-old white male, is declared a suitable candidate for beta blocker therapy for the treatment of his hypertension and stage B left ventricular systolic heart failure. Now my question to you is, in which of the cases below would metoprolol use be absolutely contraindicated? Would it be in diabetes mellitus type 2? Would it be in depression? Would it be first-degree heart block? Or would it be moderate to severe hyperactive airway disease? I'll give you 10 seconds to choose the correct answer. So that would be moderate to severe hyperactive airway disease. Now, the only one of the listed comorbidities that is an absolute contraindication is the use of beta blockers in patients with asthma, which is one of the hyperactive airway diseases. This is due to the increased risk of bronchoconstriction and or spasm, especially in patients with more severe difficulty in controlling of the asthma, or those who require 2 to 3 medications to keep them under control. Now, first-degree heart block is concerning, but it isn't considered an absolute contraindication, but it's rather a relative contraindication. So, they can be used with caution in such cases. Second-degree heart block, however, or in 6 sinus syndrome, is absolute contraindication for beta blocker use. Now, just like to re-emphasize that beta blocker use in type 2 diabetes mellitus is only concerning for the masking of the symptoms of hypoglycemia. Diabetic patients will still be able to sweat, for example, since this is controlled by a physiologic mechanism that is mediated by acetylcholine and nicotinic receptors, not by beta receptors. Then depression can be worsened with beta blocker therapy, especially with beta blockers that are lipophilic, such as metoprolol, but it is not considered a contraindication for use of beta blockers in depressed patients. So A, B, C are wrong. I would consider D as the correct answer. Let's move to the next question, which reads, BAL is a 26-year-old female who has a hemodynamically unstable pulmonary embolism. She was previously on heparin at a dose of 18 units per kilo per hour, which is now withheld to allow for antiplatelet administration as a 120 minutes continuous infusion. Now, on completion of the antiplatelet 120-minute infusion, her PT was 13.1 seconds and her APTT was 45.8. My question to you is, which of the interventions listed below would be the most appropriate after completion of the alteplase infusion? Would you opt to restart the heparin with a dose of 60 units IV as a bolus? Would you opt to resume heparin at a dose of 18 units per kilo per hour? Or would you start warfarin 10 milligrams orally once a day? Or is it true that anticoagulation must be withheld for 24 hours? I'll give you 10 seconds to choose the correct answer. Comfortable to resume heparin at a dose of 18 units per kilo per hour. Now, the CHEST guidelines recommend checking the APTT immediately after completion of the alteplase infusion, and provided that the APTT isn't greater than 80 seconds, restarting IV heparin without a bolus at the same infusion rate as before the TPA was started would be in order. Now, warfarin could be started, but only if concomitantly we are administering heparin. I would not use it as monotherapy. Then anticoagulation therapy must be continued after fibrinolysis for a PE. I would not withhold it for 24 hours. I would continue it to avoid another clot, just for your information. So I would settle for B as the correct answer. And just like to remind you that patients receiving alteplase for acute ischemic stroke generally don't receive any anticoagulants or antiplatelet agents for 24 hours after the end of the alteplase infusion. So the last option D would apply to them, to patients who have had an acute ischemic stroke, not PE. Then patients receiving systemic IV alteplase for PE may require further intervention, including catheter-directed thrombolysis or surgical embolectomy if things don't go very well. Now, lower doses of alteplase, that is 50 milligrams IV, are being investigated currently for use in patients with submassive PE. Hopefully in the future we might see lower doses being used instead of the 100 milligrams as it stands right now. Let's move to the next slide, which reads, which of the drugs listed below is the preferred or the first-line choice for the treatment of patients presenting with supraventricular tachycardia, which has failed to respond to vagal maneuvers? Is it amiodarone, adenosine, atenolol, or diltiazem? I'll give you 10 seconds to choose the correct answer. So adenosine it is. Adenosine is a miscellaneous antiarrhythmic agent that is considered first line in SVT due to its ability to increase the removal of potassium out of the cell, leading to the inhibition of the AV nodal conduction. Now, none of the other drugs listed is considered the drug of choice in SVT. Adenosine has a very short half-life of less than 10 seconds and thus should be administered by a rapid IV push, followed by a 20 ml saline flush into the most proximal available IV site. Don't push it slowly, otherwise it would be metabolized and rendered useless. Let's move to the next slide. In which of the patient cases listed below isn't there an indication for IV fibrinolytic therapy? Is it a patient with a true posterior MI, or a patient with an acute STEMI, or a patient with a presumed new LBBB, or finally, is it a patient with an N-STEMI? I'll give you 10 seconds to choose the correct answer. So it would be a patient with an N-STEMI. Now, IV fibrinolytic therapy is indicated in patients with a STEMI, with a true posterior MI, or with a presumed LBBB within 12 hours of symptom onset. But IV fibrinolytics are not indicated in patients with N-STEMI. Let's move to the next question. Which of the drugs listed below has the potential to inhibit the activation of Clopidogrel, thereby putting the patient with a recent placement of a drug-eluting stent at an increased risk of thrombosis? Is it a patient on ranitidine, lansoprazole, aluminum hydroxide, or metoclopramide? I'll give you 10 seconds to choose the correct answer. So lansoprazole it is. Now, the activation of clopidogrel is mediated by the CYP enzyme system. Now, any drug that inhibits those enzymes, especially the CYP2C19, such as the PPIs like lansoprazole in case B, will decrease the activation of clopidogrel and reduce its ability to exert its protective antiplatelet properties. Now, the other listed drugs aren't major inhibitors of those pathways, and they don't interact with clopidogrel as such. Let's move to the next question. NOL is a patient with newly diagnosed stage C heart failure who is being evaluated in the cardiac clinic at your hospital for initial medical treatment. He is currently hemodynamically stable with a systolic blood pressure of 149 and a diastolic blood pressure of 93 and a heart rate of 80. His chief complaints are dyspnea and fatigue, and is found to be having 1 to 2 plus pitting lower extremity edema bilaterally. My question to you is, which of the listed pharmacologic options would offer him both morbidity and mortality benefits and would be considered as part of his initial medical treatment? Would it be furosemide, digoxin, metoprolol tartrate, or lisinopril? I'll give you 10 seconds to choose the correct option. Lisinopril it would be. Of the listed agents, lisinopril, the S inhibitor, has both morbidity and mortality data in heart failure patients, while metoprolol succinate, the extended release form to be specific, has both morbidity and mortality data. Metoprolol tartrate, which is our option C, the regular release twice daily dosing, doesn't have morbidity or mortality data at all. And neither furosemide nor digoxin has mortality data, but both of them have morbidity data. Now, digoxin in patients with a left ventricular ejection fraction of below 40, according to the DIG trial from the 1970, proved beneficial. So I would opt for alternative D as my best bet. D would be the best opinion. Sorry, the best choice in my opinion. So let's move to the next slide. That brings us to the end of part 26 of our pharmacotherapy MCQs. So thank you very much, my esteemed viewers and listeners, for being there for me and for watching this particular video. Now, if this video helped you in any way, I would like to remind you to give it a thumbs up and to like it and to share it widely with your friends and peers. Now, I'd like to promise you that the best is yet to come. For those who haven't subscribed, I would like to urge you to subscribe to my channel. So I look forward to interacting with you in part 27 of our series. Thank you very much for watching and for listening.